Well, in this video we want to clarify the pressure changes that take place during inspiration and expiration, with particular reference to the role of the pleural membranes. So here we have the chest. As you probably recognise, we have the trachea. This will be the left lung, this will be the right lung, main bronchi. And these are the ribs, 12 pairs of ribs. And we're just going to put on the diaphragm. So the diaphragm is this dome of muscle here, in orange in this case, actually separating the abdominal and the thoracic cavity. So that's the diaphragm there, this dome of muscle. Now I want to put on the pleural membranes. The pleural membranes. Now there's two pleural membranes. The visceral, I'm going to draw in green in this video, so anything green is going to be visceral. So here's the visceral pleural membrane around here, adherent to the surface of the lung. The visceral pleural membrane, and of course around the surface of each lung. The visceral pleural membrane. And then lining the surface of the thoracic cavity, the internal surface of the thoracic cavity, we have the parietal pleural membrane, which is going to be around here, lining the inside surface of the chest. Also lining the superior surface of the diaphragm, adherent to the superior surface of the diaphragm. And each lung has its own. It's enclosed in its own pleural sac. So visceral in green, parietal in red. Now we're ready to start thinking about the pressures. Now, just before inspiration begins, the pressure inside the lungs, and we can call that the intrapulmonary pressure. So intrapulmonary means inside the lungs. The intrapulmonary pressure in here. And this is going to be the same as the pressure in the alveoli. So the alveolar and the intrapulmonary pressure are actually going to be the same. That's the pressure in here. And another way of describing this is the barometric pressure. Baro means to do with pressure, the barometric pressure. And the pressure inside the lungs, just before inspiration, is going to be the same as the pressure outside. Now, the pressure of the atmosphere is measured in millimeters of mercury. And the normal pressure in the atmosphere is 760 millimeters of mercury. 760 millimeters of mercury at sea level. So the barometric pressure is 760 millimeters of mercury outside, and before we start breathing in, it's 760 millimeters of mercury inside. The intrapulmonary or the alveolar pressure is the same as outside. So we could call this 760 or we could call it 0. It doesn't really matter too much. Now, if you're interested, I wouldn't recommend this, but if you go up to the top of Mount Everest at 8,800 odd meters, the pressure will drop to about 250 millimeters of mercury. And even if you only go to base camp at 5,400 meters, it will be 400 millimeters of mercury. So I wouldn't recommend that really. But here at sea level, 760 millimeters of mercury, and we call this 1 atmosphere. We call this 1 atmosphere. Now, to breathe in, of course, we need the diaphragm to go down. The diaphragm will go down and flatten, and the intercostal muscles will pull the ribs up and out. So those things will both increase the volume of the thoracic cavity. And when you increase the volume, you decrease the pressure. And the reason for this is Boyle's law. And Boyle's law says this: P1 times V1 equals P2 multiplied by V2. So P1 V1 equals P2 V2. So what this means is, at the start, in a closed system, at the start of the activity, the pressure times the volume is going to be the same as the pressure times the volume at the end of a process. So at the start of inspiration, P1 V1 is going to equal the same as the pressures at the end of inspiration, which is P2 V2. Now what this means is that there's an inverse relationship between pressure and volume. That's what it means. So when the volume goes up, because the diaphragm and the intercostal muscles go up and out, the diaphragm goes down, that's going to increase the volume. Therefore, to obey Boyle's law, that will reduce the pressure. It will reduce the pressure. Now, during quiet breathing, the diaphragm's only going to move by about a centimetre. So quiet at rest breathing, the diaphragm's going to go down by about a centimetre in U. And that is going to reduce the pressure in here, in the lungs, the intrapulmonary pressure, by 1 to 3 millimetres of mercury. Let's say about 2 millimetres of mercury. So because the volume is increased, the pressure in here is going to drop by 2 millimetres of mercury. And that's going to mean about 500 mils of air is going to come in to equalise the pressure. 500 mils of air is going to be sucked in. And that is the normal tidal volume, about 500 mils of air. That's in quiet breathing. But if you go for a vigorous workout, then that's going to change. The diaphragm's going to move down much more dramatically. And the ribs and the external intercostal muscles are going to pull the ribs up more dramatically as well. So during a big workout, this can move down by about 10 centimetres. And that will cause a much bigger change. That can cause a 100 millimetre drop, 100 millimetres of mercury drop in the pressure. And that means the big pressure changes. Of course, air always goes from areas of high pressure to areas of low pressure. Big pressure changes means the lungs are going to fill up really quickly with 2 to 3 litres of air, which of course is exactly what we need to get the oxygen in, to supply oxygen to our rapidly metabolising muscles. So that's what happens normally. There are problems, of course, because remember the diaphragm accounts for about 75% of the change in ventilatory volume. So in pregnancy, it can't go down as easily. In obesity, or if there's external pressure on the abdomen as well, such as after accidents or with tight clothing, that can reduce ventilatory efficiency. So quiet breathing, 75% of the volume change is the flattening of the diaphragm, and 25% is the ribs going up and out due to the contraction of the external intercostal muscles. Now, just before we breathe in, the pressure in the pleura between the pleural membranes is going to be about minus 4 millimetres of mercury. Now, why is there a negative pressure in between the pleural membranes? So, visceral pleural membrane in green, parietal pleural membrane in red. There's a negative pressure here. Now, I've drawn this here as a gap. In actual fact, in life there is no gap. The visceral pleural membrane and the parietal pleural membrane are sucked up against each other. So what's generating this negative pressure? Well, the lungs themselves are elastic. So the lungs are always trying to fall in the way. So the lungs are always trying to move in the way like that, because the lungs are elastic. They want to move in the way. But the chest wall and the diaphragm are pulling the parietal pleural membrane the other way. They're pulling it that way, and they're pulling it that way. So really what you've got is a kind of tug of war. You've got the lungs trying to pull the pleural membrane down, and the ribs and diaphragm trying to pull it out. So you end up with this negative pressure. But it doesn't separate because the other main factor here is the surface tension. Now, in here, in the pleural space, which is not actually a space, it's a potential space, there's actually a thin layer of fluid, and this fluid is essential for the surface tension that's going to hold them together. So the lung elasticity is pulling it in, the chest wall is pulling out, and the surface tension is holding it together. And we end up with this negative pressure of about 4 millimeters of mercury. Now, what I want to do is demonstrate what actually happens when the chest wall moves up and out, because this is essential to grasp. Now, I'm hoping my colour coding is going to work, but what I have here is a parietal pleural membrane, and what I have here is a visceral pleural membrane. So we've got the parietal pleural membrane, that's going to move up and down with the ribs and the intercostal muscles. It's going to move up and down with the ribs and intercostal muscles. Now the parietal, and of course that's the parietal is attached to the chest wall, so that's going to move with the chest wall. Now this is adherent to the surface of the lung. This is the visceral pleural membrane in green. And between the two there is a layer of fluid, as we've said. So we need to add a bit of fluid to this situation. There we are. Be a bit much, but never mind. Now, these are stuck together. Unfortunately, my die's coming off. But I think you can see what's happening here. So what we can see is when the chest wall moves up and out, I'm holding on now to the parietal pleural membrane. I'm not cheating, I'm not holding on to the visceral pleural membrane. What's happening here is the atmospheric pressure is holding them together. So when I move the parietal pleural membrane up and out, or down with the diaphragm, the visceral pleural membrane is moving with it. These two membranes move together. They move together because they're stuck. They've adhered to each other with this surface tension. A bit more water. There we go. So we can see they're held together with the surface tension and move together. So that's what's happening here when the ribs move up and out and the diaphragm moves down. So it's the ribs moving up and out, diaphragm moving down, that's going to take the parietal pleural membrane with it. And because the visceral pleural membrane is sucked onto the parietal, the two are going to move together. And that is how the volume increases. That is what actually increases the volume of the lungs. And when you increase the volume, you reduce the pressure, so the air is going to be sucked in. And I've got another diagram that explains this here as well. So what we see here is this is the situation at rest. So at rest, we have 760 millimeters of mercury pressure inside the lungs, or in the alveoli. That is our intrapulmonary pressure. And the pressure between the pleural membranes, the intrapleural pressure, is -4. That's at rest. But then the ribs move up and out, take the parietal pleural with it, the diaphragm flattens. That's going to increase the volume, therefore reduce the pressure, and that's exactly what we see happening here. So we see during inspiration, the pressure here is now 758, which is 2 millimeters of mercury below the 760 atmospheric pressure. Because outside, of course, it's still 760. That's why the air is going to be sucked in to equalize the pressure, because air moves from areas of high pressure to areas of low pressure. And because at this point the ribs are moving up and out and the diaphragm's moving down, that's pulling on the parietal pleural membrane in all directions, because of course there's no gap here. This is all directions. So what actually happens during inspiration is the intrapleural pressure goes to -6 millimeters of mercury. There's a greater negative pressure there. So that happens during inhalation. Then during exhalation, the next stage, now the diaphragm has gone up. You can see the diaphragm's domed up. Again here you see it's flat there, but domed up there. The ribs have gone down and in. That's going to reduce the volume in the chest. When we reduce the volume in the chest by Boyle's law, we reduce the volume, so we increase the pressure, and we now, again with gentle breathing, the pressure changes will be much more dramatic if you're exercising. But at gentle breathing we've got +2, and that's going to blow the air out again. And in this situation, because the ribs are no longer pulling the parietal pleura up and out, and because the diaphragm's no longer pulling the parietal pleura down, the intrapleural pressure goes back to -4, ready to start the next respiratory cycle. Now, if there's vigorous breathing going on, if there's exercise going on, what are called the accessory muscles of respiration also take part to inhale, to increase the efficiency of inhalation, to make more inhalation happening. So there's the sternocleidomastoid muscle, which will contract, pulling up the sternum. There's the scalene muscle, which will pull up the first 2 ribs, and there's the pectoralis minor muscle, which will pull up the 3rd and the 5th ribs to increase the efficiency of the expansion of the thoracic cavity during vigorous exercise. Now, the expirational process is one of passive recoil. This is just a passive recoil process. So it takes active muscular contraction to get from this stage to this stage, but with gentle breathing at rest, to get from this stage to this stage, it's just a passive recoil process. There's a elastic passive recoil. The diaphragm when the diaphragm relaxes, it goes up. So the diaphragm is relaxed in its domed up position. The diaphragm is contracted when it flattens. So the diaphragm will naturally move up and relax, and the chest wall will move down and in. Alveoli themselves are also very elastic, and there's elastic tissue throughout the lung as well, facilitating this process. But there's another factor here, the inward pull of surface tension due to the film of alveolar fluid. And this actually accounts for most of the elastic recoil. It's the alveoli actually sucking everything back together again. And of course, it's important to know about this idea of surface tension within the lung because of the presence of surfactant, which reduces the surface tension. Now, the surfactant is actually a mixture of phospholipids, that's fat and phosphates, and lipoproteins, that's fats and proteins. And it's present in the alveolar fluid, and it reduces the surface tension of the alveolar fluid to less than pure water. And a deficiency of surfactant in premature infants causes respiratory distress syndrome. And here the surface tension of the alveolar fluid is increased because it hasn't got the surfactant to reduce it. So many alveoli will collapse and stick together at the end of each exhalation. The alveoli will actually stick together and then they can't get apart because the surface tension is too high, because the surface tension has not been reduced by the surfactant. And great effort is then needed in the next inhalation to reopen the collapsed alveoli. Now, as we've said, these are the pressure changes which occur with gentle breathing. With vigorous breathing during exercise, it's going to be much more. And just like the process of inhalation, was enhanced by accessory muscles of inhalation, there's accessory muscles of expiration as well. So the abdominal muscles will contract. So the abdominal muscles down here are going to contract. And that's going to pull the inferior ribs down a little bit. So the inferior ribs are going to be pulled down, because down and in is going to reduce the volume of the thoracic cavity. And also when the abdominal muscles contract, that's going to compress the abdominal contents, which is going to squeeze the diaphragm up, improving the upward movement of the diaphragm. But the main accessory muscles of expiration are the internal intercostal muscles, which pull the ribs down and in. So the external intercostal muscles pull the ribs up and out, but the internal intercostal muscles pull the ribs down and in. But during forced expiration, so if you're playing a trumpet or if you're out for a run and you need to breathe out more quickly, then expiration is aided by the process of contraction of the internal intercostal muscles, as that pulls the ribs down and in, decreasing the intrapulmonary volume more dramatically, therefore increasing the pressure by the equivalent amount as dictated by Boyle's law.